Hello, everybody. Welcome back to another Advanced Human Gross Anatomy lecture. Today we'll be talking about the foot, mostly the foot. We'll be talking a bit about the joints of the lower extremity and some superficial upper extremity, primarily veins and some of the muscles of the shoulder is where we'll end up today. So let's review a little bit here. The Achilles tendon. Remember, this was a combination of uh, muscles joining into this tissue from the gastrocnemius, which is the superficial muscle in the posterior compartment, the soleus, which is just deep to that. And then between those two, here you can see the plantaris muscle, but that tendon continues, that long tendon, you can see it on the outside here, forming down into that Achilles tendon, or this tendocalcaneus, or the calcaneal tendon. So the gastrocnemius, the soleus, and the plantaris are what make that up, attaching to the posterior calcaneus here. If we look at the artery supply, we'll remember that the posterior compartment off of the popliteal artery is supplied by the posterior tibial artery. Here you can see that anterior tibial going through that interosseous membrane between the tibia and the fibula, going toward the anterior compartment. But the posterior compartment is actually supplied by this posterior tibial artery, which goes right behind that medial malleolus, along with those deep muscles of the posterior compartment, the flexor digitorum longus, the posterior tibialis, and the flexor hallucis longus. They all come on posterior to the medial malleolus. Remember, we talked about the mnemonic down the hatch, digitorum, tibialis posterior, and flexor hallucis longus down the hatch, and then that tibialis posterior kind of hooks on the other side of flexor digitorum longus, and the posterior malleolus here, where it's Tom, Dick, and Harry is how we described that before. So the first tendon there, posterior to the medial malleolus, is the tibialis posterior, followed by the flexor digitorum longus, followed by the posterior tibial artery and nerve, followed by the flexor hallucis longus. So kind of getting that order back in there. But we'll be able to see these tendons now. We saw the muscles. We'll see those tendons as they continue onto the bottom of the foot later today. What I'd like you to start with in lab today is to take the skin off the plantar aspect of the foot. Now, this is actually quite dense tissue. It's very thick. It's kind of hard to separate these tissues. It's a little more complicated than removing skin that you've experienced before. The tissue just is much more dense and thick. But you'll get it, I'm confident. What you'll notice here is Netter has drawn this beautifully dissected plantar fascia where the skin is taken off, and you can see this plantar aponeurosis, it's called. So it's this thick, dense connective tissue here that comes from the calcaneus and goes all the way into the phalanges here, but a strong anchor at the metatarsal heads. If you've ever stepped on a nail, I hope you haven't, but if you've ever stepped on a nail, maybe you heard a pop as it pierces through this dense connective tissue here. Plantar fasciitis is often a very common inflammatory issue seen in the clinic. This condition where it's kind of a telltale sign of plantar fasciitis is painful first steps in the morning hours. And imagine sleeping with your ankle relaxed and slightly plantar flex, and all of this tissue on the bottom of the foot is short and relaxed. And then you wake up and you put your feet on the ground and you jump out of bed. And now all of that tissue is immediately brought into dorsiflexion. And if it's irritated at all, it's going to have either irritation at the calcaneal insertion here or into the mid-substance of that plantar aponeurosis. But pretty tough to walk on. Can be quite challenging. This plantar fascia is very thick, it's very strong, and people who live in cultures that don't wear shoes, for those of us who have protected our feet most of our lives, it's not quite as thick and strong, but depending on where the donors are where they lived much of their life that we're going to be working on, it may be quite thick. Looking at the blood and nerve supply again here from that posterior tibial artery, here you can see the medial aspect from the medial malleolus here coming posterior to that. Here's that posterior tibial artery that will then split into a lateral and medial posterior artery. They will join up. They'll kind of tuck underneath this quadratus plantae muscle, which we'll talk about in a little bit. And then make an arch here, kind of this plantar arch that we'll see. Now the nerves do the same thing. That tibial nerve rather will come down with the posterior tibial artery and also split into a lateral and medial plantar nerve. So you should be able to kind of notice those as well. But the arteries will kind of off of that plantar arch will give branches on the sides of the metatarsals, into these metatarsal arteries, which will then split into these digital arteries on the sides of the digits as it goes toward the toes. So you should be able to maybe expose some of those things as you see it. Now, what I'd like you to do is to go back and, let's see here. Here it maybe shows, there's a better shot of that arch where the medial and lateral plantar arteries and nerves branch off of the posterior tibial artery and the tibial nerve coming under this musculature here. And then off of that coming into these metatarsal arteries, then off of that coming into the digital arteries here. But what I'd like you to do before we get to all that is to see this plantar fascia. Take a blunt probe and just kind of separate it from the underlying tissues here. It'll be strongly attached to the calcaneus and to the metatarsal heads, but what you can do is stick a blunt probe through here and kind of run it up and down, separate that tissue from the underlying tissues. And then I want you to cut this plantar fascia from its calcaneal attachment and then flip it forward to expose the underlying musculature. And what we'll see is 3 distinct layers. Now here you can see Netter has taken the plantar fascia off. We're not going to do that. We're just going to cut it here and then flip it forward so we can notice these underlying tissues. Now there's 4 distinct layers of tissue beneath the plantar fascia on the bottom of the foot. You didn't know it was that complicated, but it is. There's a lot going on at the bottom of the foot. The first 3 layers are more muscular and tendinous, and then the 4th layer is basically just bones. There are some muscles that we'll talk about in that 4th layer between the metatarsals, but consider the first 3 layers the meat of the foot. The first layer here, from superficial to deep, the first layer is you'll see the flexor digitorum brevis. Now this muscle comes from the calcaneus. You can see it's just deep to the plantar fascia, and it goes to the middle phalanges of the digits 2 through 5, kind of coming in through here, right to those middle phalanxes. Right through here is the flexor digitorum brevis. You'll also see the abductor, the abductor digiti minimi. Right here on the outside, the abductor digiti minimi, coming out to from the calcaneus again to the base of the proximal phalanx of digit 5, right here, which is responsible for abducting the little toes, just a little toe, one on each side, obviously. And then you've got the abductor hallucis muscle, which is right here, again from the calcaneus, big attachment site of muscle, to the base of the proximal metatarsal of digit 1. The proximal phalanx of digit 1, which is responsible for abducting the great toe, kind of bringing it wide. So to splay your toes, you would engage these abductor digiti minimi and abductor hallucis musculature to kind of pull your toes apart. Okay, now the second layer, to get to the second layer, what I'd like you to do is cut that flexor digitorum brevis muscle. So just like what we did with the plantar fascia, you're going to stick a probe underneath that muscle here. Let's go back to this one. Stick a blunt probe underneath this, and then you're going to flip it forward to expose the second layer, kind of pulling on those tendons as they attach to those middle phalanx of the second through 5th toes, pulling it forward just like we did the plantar fascia. And now you can see the second layer of musculature, the second layer deep. Now what you'll see here is this flexor hallucis longus. Remember this one? This is those muscles in the deep posterior compartment of the leg. Flexor hallucis longus going to the distal phalanx of the great toe. And then guess where this one is? The flexor digitorum longus. That's coming into here. Flexor digitorum longus going down deep here. Here it's interesting. You can see the flexor digitorum brevis kind of splits, makes this little Y shape as it attaches to the proximal phalanx, or the middle phalanx here. And this is going to then, the flexor digitorum longus is going to go in between that, kind of like it's going to go between the legs of that split there and attach to the distal phalanx of each of the 4, the 2nd through 5th digits there. And then you've got this muscle here, a very interesting muscle, the quadratus plantae. Now here's that word again, quadratus. The Greeks, when they saw a muscle with 4 sides, they like that word, quadratus. But now we're going to call it the plantae because it's on the bottom of the foot. This is again from the inferior calcaneus to the tendon of the flexor digitorum longus. So this is just extra reinforcement to help really pull on these flexors of the toes. And this is important for balance. It's important for explosion of taking off. If you're going to start running quickly or anything like that, that's going to be an important part of that tension there. Now, another interesting part about the second layer is another muscle, these muscles called the lumbricals. Lumbrical literally means worm, lumbrical. So the lumbricals are just these worms. You can see them here coming off of the tendons of the flexor digitorum longus. So remember, that has its own muscle into the deep posterior compartment of the leg. It's also coming into it is this quadratus plantae, and then coming off of it are these lumbricals, and these go to the medial bases of the proximal phalanx, the phalanges, to all of the extensors and the extensor hoods of digits 2 through 5. So into the extensors right through here. You think, well, that's kind of funny. Why would there be a muscle here coming off of the flexor, going to the extension of the proximal phalanx? That's interesting. So think about this. When the flexor digitorum longus engages, when you contract that muscle, it will want to pull the toes into flexion, right? It's going to curl them down towards the base of the foot. But when you're running or you're jumping, and you don't necessarily want the toes to curl down, this muscle, these lumbricals, when the flexor digitorum longus engages, it will then extend the toes. It will, when pushing off, it would be better if the toes stayed straight to allow the metatarsals and the toes to flex together, kind of like a paddle. It's going to push down together. So the contraction of the flexor digitorum longus and the quadratus plantae will activate these lumbrical muscles to keep the toes straight and stiff, in essence keeping the metatarsals and the toes to push off together. Isn't that amazing? That you'd think it would work one way to kind of curl together, but you want one part to stay straight as the whole thing bends as one unit. So these lumbricals, as they attach into that tendon, I just think that's really cool. All right, now let's go another layer deep here. The third layer, let's take that off. Now, again, you're going to cut the quadratus plantae. Here you can see it cut off here, the quadratus plantae. But be careful here. Cut it off of its calcaneal insertion, and reflect it forward, just like what we've done with the others, the flexor digitorum brevis and the plantar fascia. But try to preserve, if you can, these medial and lateral plantar artery and nerve, if you can. Try not to disrupt that as you cut that quadratus plantae off. Now, in the fourth layer here, what you're going to see is the flexor hallucis brevis muscle. Now, this is just another muscle all by itself here, the flexor hallucis brevis, coming up underneath the flexor hallucis longus. From the calcaneus, again, medial and lateral cuneiforms, as well as the cuboid it comes off of there too. And it goes all the way to the base of the proximal phalanx of the great toe. So it's going to help bend the great toe, just like the flexor hallucis longus, which actually goes to the distal phalanx here. And then you can see the flexor digiti minimi brevis right here, this muscle. Now this is part of its own. It's its own muscle coming off of the base of the fifth metatarsal. It's kind of a short muscle. The base of the fifth metatarsal going to the proximal phalanx of the fifth digit down here. And this is interesting because the flexor digiti minimi doesn't have a longus. That's kind of it's an oddity to be named that. Usually in anatomy, if you have a brevis, you'll have a longus, but really the flexor digiti minimi longus is just the flexor digitorum longus. Remember that tendon comes down and attaches the second through fifth distal phalanxes here. So that comes all the way down. So there isn't a flexor digiti minimi longus. That's just the extensor. I'm sorry, the flexor hallucis. No, the flexor digitorum longus. But there is this flexor digiti minimi brevis, which is interesting. Now, you'll also see this funny looking muscle here. Now, this is a different muscle because this is on the bottom of the right foot. It looks like a 7. You see this here, this adductor hallucis muscle. Hallucis referring to the great toe, adductor, adductor, pulling it toward the midline. So on the bottom of the left foot, it would look like a backward 7. But so you can see these two heads here of this one muscle. Now it has a transverse head right here. You can see from the deep transverse metatarsal ligament of the 2nd through 5th metatarsals here. The digits coming over, and then the oblique head coming at an oblique angle this way from the base of the metatarsals of the 2 through 4 here, and the cuboid and the lateral cuneiforms, but they're all going to the lateral aspect of the base of the proximal phalanx of the great toe. And again, its job is to bring the big toe together. So the abductor hallucis is going to bring it away, display it. The adductor hallucis is going to bring it towards midline, keeping that big toe from spreading out too far as this muscle, the adductor hallucis. Okay. Let's move on now to the 4th layer. We take that off, and now really you've just got this, it's just bones. You've got the metatarsals. But there are these muscles in between the metatarsals called the interosseous muscles here. You can see the interossei here and here, the dorsal portion and the plantar portion of the interosseous muscles. So these have a kind of a herringbone look to them. You can kind of see how they kind of weave back and forth like this. Kind of a pretty little muscle. But it has both plantar and dorsal interosseous muscles. Now, one way to remember this, the way that I think about this is if you've ever been to a concert or a show or a play or a museum or something where you got in and they stamped your hand with a rubber stamp to indicate that you've paid your cover charge or whatever to get in. They put that rubber stamp in a dab pad, an ink pad that they'll dab, and then they'll stamp it onto your hand. They dab it in the ink, and then they put it onto your hand. That dab pad. So that phrase, dab pad, DAB PAD, dab pad. Think about that as dorsal is going to abduct. Right? These tendons are going to abduct. They're going to bring away from midline the toes, the metatarsals, pull the digits apart. The plantar aspect, pad, the PAD, plantar is going to adduct, so pulling the toes closer together. So the dorsal interossei, abduct, the plantar interossei, adduct, dab pad. Hopefully that's helpful to you. So on the dorsal aspect of the foot, let's go here. Let's just talk a little bit about the dorsal part. Now again, we've seen these tendons before, but you'll remove the skin to expose these underlying structures of the dorsum of the foot. And you'll see here the extensor hallucis longus, this bit long tendon coming down to the extensor, the dorsal side here coming down to the toe to extend the great toe. You'll see the extensor digitorum longus, which comes on the top here. Remember, it splits into the 4 tendons that come down to these 4 digits 2 through 4 coming down to the distal phalanxes. And then there's this funny one here, this fibularis or the peroneus tertius muscle off of that extensor digitorum longus. Don't get that confused. If you say this stuff too often, you start to get confused about flexors and extensors. Extensors are on the dorsal side, flexors are on the plantar side. Hopefully that's pretty clear. If I've screwed up saying that in these lectures, I apologize, but hopefully you'll get it. The extensor digitorum longus has that kind of rogue muscle here, this fibularis tertius tendon that also comes down to that 5th ray there. The extensor digitorum brevis, you can see kind of underneath here, coming down, the extensor digitorum brevis coming down to the proximal phalanges, to the toes of 2 through 4. Here you can see to the middle phalanxes. You can see that the extensor, let's see, what else do we want to see here? Extensor hallucis brevis. You can see that extensor hallucis brevis right here, just coming down to the proximal phalanx of the great toe. So the brevis is going to go to proximally, and the longus is going to go distally. It's going to go further to extend the other joints of the toes. Okay, let's see, what else we want to talk about here. The anterior tibial artery descends down into the anterior compartment. Remember, through that interosseous membrane off the popliteal artery, comes down here. You can see it just continues on the dorsum of the foot as the dorsal pedis artery. Remember, that was the artery we talked about between the first and the second metatarsals here, were commonly used by physicians, where they'll kind of put their thumb in the arch and their fingers on top of the foot here to kind of palpate the pulse of the dorsal pedis artery to check for peripheral artery circulation. If you've got a good pulse, that's what we're looking for here. But again, that dorsal pedis artery will arch over the top of the foot, giving this dorsal arch here, and then just like the plantar arch, will come down off of those the metatarsal arteries, and then the joining into the digital arteries, eventually coming into the toes. So again, the two arches here, the dorsal and the plantar arches off of the anterior tibial artery, and then on the back posterior compartment being the posterior tibial artery. All right, now let's see, dorsum of the foot here. Let's continue on and talk about the deep fibular nerve. That's one to talk about here. The deep fibular nerve, remember, that's going to supply the anterior compartment. The superficial fibular nerve going to the posterior compartment, as we saw before, runs along with the anterior tibial artery, continues down into the dorsum of the foot as well, kind of right through here. So along with the dorsal pedis artery, you should also be able to find that deep fibular nerve. Okay. Now we'll talk about some of the joints of the lower extremities here. Now, instead of disrupting the beautiful dissections that you've done already, I don't want to destroy some of those to get to these joints. So instead of doing that, I think we'll benefit mostly just from an understanding them through the pictures and the models, just again in an effort to preserve the dissection that we've done so far. But the first joint we'll talk about here is the hip. Talk about the hip joint. Hip joint's a very stable joint. You've got a ball of the head of the femur sitting into the acetabulum, the socket of the pelvis. So it's already about 40% of that ball is contained within that acetabulum. It's got a very good surface area contact. Plus, it's a weight-bearing loaded joint. It's pretty stable. But on top of that now, you've got all these ligaments, these three big ligaments that help hold the hip together. On the front side, you can see here the iliofemoral ligament, the anterior view here of the right hip, the iliofemoral ligament coming down from the ilium to the greater and the lesser trochanter of the femur here. You can kind of see it's got two bands, kind of make a Y shape there. There's an pectineal bursa that sits right over here from that where the pectineus will kind of fall over. Gets irritated when you're working on a lot of hip flexor activities. That's what that is right there, but right in front of the iliofemoral ligament from the ilium to the femur. Now on the back side, you've got the ischiofemoral ligament here, from the ischium over to the femur. So from the ischium to the posterior aspect of the femur here, stabilizing it from the posterior aspect of the hip here. Iliofemoral stabilizing anteriorly, ischiofemoral stabilizing posteriorly. And then back to the front view here, you've got this pubofemoral ligament here. So from the pubic bone on the bottom to stabilize inferiorly from the pubic bone to the inferior neck of the femur, right on the underside here. So you've got an anterior stabilizer, iliofemoral. You've got a posterior stabilizer, ischiofemoral. And you have an inferior stabilizer, pubofemoral. Very, very strong, tough ligaments. So those three ligaments, again, along with the seating of the femoral head within the acetabulum, as well as, we didn't talk about the labrum, this acetabular labrum, which is this fibrocartilage rim that gives a little bit more false deepening of that socket of the acetabulum. All of this really make for this to be quite a stable joint. If you ever meet anybody who has dislocated their hip, ask them how. That's going to be a fantastic story. Not really. It'll be a tremendous story, but it will probably be a pretty ugly story, really. How do you dislocate a hip? It takes really quite some trauma. Now, on the inside of the joint here, you can see the hip has been dislocated. Here's this depression, this fovea capitis. Fovea is kind of a depression. Capitis, the head of the femur, the depression within the head of the femur here, the fovea capitis. And that is the attachment of the ligament of the head of the femur. Now, I'm not kidding, that's what it's called. That's what they decided to name it. It's a ligament. Guess where it is? It's on the head of the femur. Maybe we should call it the ligament of the head of the femur. But that's where that is. Sits right into this fovea capitis. And that will also help stabilize the head of the femur into the acetabulum. Accompanying that that ligament of the head of the femur is an artery, and if you do dislocate the hip, as this picture indicates, you will break that artery and you'll hemorrhage. But the troubling part there is you may also disrupt the blood supply to the head of the femur, in which case you may get some avascular necrosis, some death of the tissue because it no longer gets blood supply, and you may be looking at a premature total hip arthroplasty in your future. So be careful of that. Okay, let's move on and talk about the knee joint. The knee joint's not an uncomplicated joint. It is just a hinge. It is 3 bones. It is 4 ligaments. It moves in one plane of motion. It's a little more complicated than that, but it's not an uncomplicated joint. But I believe it's one of the least complicated within the kinetic chain of the leg. But its job is to flex and extend, right? So it flexes and extends. What I'd like you to do is to flex the knee up of the cadaver, and I'd like you to cut. You can see here the attachment of the quadricep musculature, where the quads come down and they attach that to that tibial tuberosity, as well as just a broad insertion along the anterior tibia. I'd like you to cut that quadricep attachment off from the tibia below the patella, right through here, and then bend up that knee. You may need to take a scalpel and cut some of that lateral tissue and the medial aspect of that knee joint line just to create some space there. And then you're going to lift up the patella. You're going to kind of bend up the knee so it kind of looks like this. You'll see the underlying structure here. Let's see, I got to get my orientation. We're looking down. Here's the condyles of the what are we looking at here? The patella. Oh, this is it. So they've pulled it down. I see what this picture is looking at. They've pulled it down. They've cut above and pulled down. We're actually going to cut below and lift up. So that's going to make it a little more easy. That's why I was getting confused here. You can see the patella is just housed within the tendons of the quadricep musculature here. So you'll be able to notice that. But as you lift it up and bend up the knee joint, oftentimes we'll be able to see either some deterioration at the femoral condyles and the tibial condyles, or sometimes you'll find somebody with a knee replacement. If that's the case, try to pick that knee. That might be interesting to look at, to be able to see, to expose the joint inside. So what you'll see are the, let's maybe go to the, let's go to this picture here. You'll see the medial and lateral condyles of the femur right here. You'll see the lateral and medial condyles of the tibia here. You'll also see the medial and lateral menisci. These are just fibrocartilage discs that help pad and cushion the knee joint as you load it. They also help give a good contour, good shape as the femur attaches to the tibia. These condyles of the femur attaching to a fairly flat tibia, that helps create a little bit more surface area for contact there. And then what you'll notice maybe here's a different shot of this. The condyle of the femur is sitting on the condyle of the tibia with the meniscus sitting out there. Now what you'll see on the outside, this helps stabilize, it's been cut here, but this iliotibial band, the IT band, is actually quite fascinating structure to look at. Again, it's kind of a brilliant white mother of pearl kind of looking structure, but it's very thin. It's very tough to stick a blunt probe through it. This lateral, this IT band and this iliotibial band or iliotibial tract, it does help stabilize the lateral aspect of the joint, though, of the knee. You'll also see on here, you can see the ligaments here. Here's this LCL, the lateral collateral ligament, or the fibular collateral ligament, sometimes called, coming from the lateral condyle of the femur, going down to the head of the fibula, and that will help support the knee laterally here. On the inside, you've got this MCL, the medial collateral ligament, coming from the medial condyle of the femur down to kind of a broad attachment into the medial condyle of the tibia, and that's going to come down. It also has an attachment into the medial meniscus too, and that's going to help stabilize the knee medially. So think about stressing these joints. If you were to hold the ankle and then put your palm of your hand at the inside of a knee and push straight laterally on a straight extended knee, pushing laterally, you can imagine kind of gapping the outsides of these joints. So from the tibia to the femur, kind of gapping that. That's going to be a test to test the integrity of that LCL, the lateral collateral ligament. If you were to keep that knee straight, hold the ankle as a little counterforce, and then push laterally at the joint line, pushing straight medially, pushing on the lateral aspect, pushing medially, kind of gapping the medial aspect of the femur from the medial aspect of the tibia, you're actually stressing. It's a test to test the integrity of the MCL, the medial collateral ligament there. All right, and then you've got these cruciate ligaments. Now, cruce means crossing. It's the same root as we get the word crucifix for. So these cruciate ligaments, they cross in the middle. Now, the trick here is that they're named for where they attach to the tibia. All right, so the ACL, the anterior cruciate ligament, attaches on the anterior portion of the tibia, and it runs superior, lateral, and posterior, attaching kind of to the posterior aspect of the lateral femoral condyle back here. Okay, the PCL attaching from, here's the backside, from the posterior aspect of the tibia, coming more, it's going to go more anteriorly and attach to the, it's going to run superiorly, but then anteriorly towards the anterior aspect of the medial femoral condyle. So it's going to go this way. So ACL from the back and PCL from the back, ACL from the front, PCL from the front. So you can see how they cross each other, but again, named for where they attach onto the tibia. Now, to test these, what you could do is bend up. If you're working on a football sidelines and somebody tears, they're worried about a tear of an ACL or a PCL, what you can do is keep the athlete lying down. If they can bend up their knee to put their foot flat on the ground, stabilizing the tibia. Their body is going to stabilize the femur because it's attached to the pelvis. But if you take the tibia below the joint line and pull anteriorly, take this, kind of put your hands behind the tibia and pull forward, you're stressing the anterior cruciate ligament. You're pulling the anterior portion of the tibia forward, which is going to stress this. Now, if there's some laxity there, now you're concerned about an ACL compromise. If you take that anterior portion of the tibia, now instead of pulling it forward, if you push it backwards, you're actually pushing the posterior portion of the tibia further backwards, and if it's nice and firm, if it doesn't give, then the PCL is fine. If it gives a little bit, if it gives further than you'd like it to, or compared to the contralateral side, the uninvolved side, now you're stressing out that PCL, the posterior cruciate ligament. So just used to kind of identify if there's any compromise in those areas there. You can also look at the menisci here, the lateral and the medial meniscus, these fibrocartilage pads on the sides of the patellar tendon. Let's see. Let me put that back. If I go back to here, on the sides of the patellar tendon, here and here, right at the joint line, there will be these fat pads, cleverly named because they're pads of fat. So again, they call them fat pads. But deep to that are these lateral and medial menisci. So you can push in there as well as with some special tests with some knee flexion and some bending and some twisting. You can kind of identify if there's any compromise clinically of those of the lateral or medial meniscus. Now, they used to just remove the meniscus. There's actually, if there was a tear, menisci have very poor blood supply. They get their nutrition from surrounding connective tissues, but they don't actually heal very well. And so they used to just take them out, and people felt great. They felt like, boy, that feels a lot better. The tear is gone. Things are really improving well. But then you start to really wear out. Now you are literally bone on bone if you have that cartilage buffer gone. So they decided that wasn't a good idea. Now they typically just cut out and remove just as much as necessary to help prevent any further joint deterioration. But you can push through that medial and lateral fat pads and kind of push onto the menisci. Here you can see just an x-ray of a right knee from an anterior view. You can see the patella, you can see the medial and lateral condyles. Medial here in the lateral condyle of the femur, the medial and lateral condyle of the tibia, and then the fibular head down here. And you look at the spacing and you think, oh, that's weird. Why aren't they connected? Well, that's where the menisci attach, or are placed here. They're located here and here. And so an x-ray is actually exposing the film. It's going through this soft tissue, exposing the film on the other side. Where you see white here is where it gets hit on the bone, the dense, hard bone. X-rays can't penetrate. They won't expose that film. You're looking at a negative here. It's kind of a joke, right? If people say that their x-rays were negative, you can just say, I thought all x-rays were negatives. But that the lateral meniscus and the medial meniscus would fit in here. If you're looking at this picture, if you're a surgeon, you might look at that and say, boy, you've got nice joint spacing there. This isn't bone on bone. You've got plenty of room in that knee joint. Now, one other area that I think is unique here on the knee, let's talk about the pes anserinus. This is a fun thing to talk about in the clinic. Pes anserinus literally translates the foot of the goose. It's this area on the medial aspect of the anterior tibia where 3 tendons will attach. And you just imagine the anatomists first doing this, thinking, that kind of looks like a goose's foot. What should we call it? Let's call it the pes anserinus, the foot of the goose. So this helps stabilize the joint medially, but really it's 3 tendons. One is the sartorius, remember, coming from that anterior superior iliac spine, crossing over on top of the quadricep musculature, coming medially, and then hooking back around to attach to the medial aspect of the tibia. Remember the Taylor's muscle, how it brings the medial aspect of the tibia up towards the anterior superior iliac spine. So the sartorius, the gracilis, coming from the pubic ramus here, coming all the way down medially, never touches the femur. And on the outside of the adductors, remember those? And it comes medially and attaches to that medial anterior aspect of the tibia. And then on the back side, here you see, remember the semitendinosus, named for its long tendon. It's being pulled here by Netter's probe that he's drawn in. But it comes down on the medial side, hooks around, let's go back to this one, hooks around right here onto the medial anterior aspect. So they looked at that and they said, oh, that looks like these 3 tendons look like a goose's foot. I guess we'll call it that. Underneath that, to protect those tendons as they attach, is the pes anserinus bursa, which is just a fluid-filled sac by design there to protect those tendons as they rub on the medial tibial condyle. So that can get irritated as well. Okay, let's move on to the ankle. The ankle, a couple of spots here. We'll just talk about briefly the medial and lateral joint lines here. The medial joint line, the medial side, there's a deltoid ligament. Delta, remember, it's triangle, this big triangular shape here. The medial ligament of the ankle, sometimes it's called, has a posterior tibio-talar ligament. The posterior tibio-talar, right here from the tibia down to the talus. The posterior tibio-talar ligament, the tibiocalcaneal ligament coming down here, the tibiocalcaneal right here down to the calcaneus here, and then you've got the tibio-navicular ligament from the tibia down to the navicular bone, and then the anterior tibio-talar ligament here. So the anterior tibio-talar, tibio-navicular, tibiocalcaneal, and posterior tibial-talar, kind of right down through here, kind of making this triangle. And so that's a very strong, it's very stabilized. You would sprain that by everting the foot, which isn't very common in this case. Now on the lateral side of the foot, if you've ever sprained your ankle, chances are it was probably an inversion sprain, putting the bottom of the foot toward the medially, straining this outside ligaments here. So remember, you've got the fibularis brevis coming down to attach the 5th metatarsal head, and the fibularis longus coming underneath to attach that middle cuneiform and first metatarsal there on the underside. That's the tendons, but the ligaments here, the calcaneofibular ligament calcaneofibular, right back here, from the fibula to the calcaneus, right? Calcaneofibular ligament, right here, sorry, that was the retinaculum. Calcaneofibular ligament. Here, you've got the anterior talofibular ligament, right here, coming on the front side, anterior talofibular, and then you've got the posterior talofibular ligament. That's what I was pointing to above here. So posterior talofibular, anterior talofibular, and calcaneofibular ligament coming up this way. Okay, so those are on the lateral side. This is much more common with inversion sprains. They're smaller, they're a little wimpier than the medial side as well. Now let's switch gears. Hopefully that was sufficient for the lower extremity. Let's start switching gears to the upper extremity. We'll talk about the arm here. Now, most of your life, again, you've called this your arm, right? The whole thing is just your arm. Raise your arms. Really, the arm is, there's 5 parts to the upper extremity. The arm is part of it, but you've got the shoulder, you've got the axilla, lots of important things we'll talk about in the axilla, the brachial plexus, the axillary arteries, and etc. coming down into here. Then you've got the arm, which is basically from the axilla to the elbow. That's your arm. And then you've got the elbow joint, then you've got the forearm, and then you've got the wrist, and then the hand. So shoulder, axilla, arm, elbow, forearm, wrist, hand is kind of how that would work coming down here. But the arm is just this upper portion from the shoulder to the elbow. So superficially, again, let's look at the venous system here. Like we did with the lower extremity with the saphenous veins. Let's talk about the superficial veins of the upper extremity. These bring the majority of the blood flow back to the heart, as opposed to just the deep veins that accompany the arteries with the same names. We'll talk about 2 particular veins here that bring blood back, not arteries, veins. So you'll see this basic pattern. Now this actually isn't the pattern. Let me show this pattern. This is kind of the basic pattern that you'll see in the antecubital fossa here in the elbow, the anterior aspect of the elbow. This is a little less common to have this kind of V shape here, this Y. But you'll see here on the medial side, let's see here. So what do I want to say here? So if you put a tourniquet on your upper extremity, you start making fists, big fists with your hands, and you can kind of pump up the veins of your arms. It might kind of look like this. Now on the medial side, you'll start to see these veins come off here. You'll have a basilic vein. That's going to be on the little finger side, all right? So remember anatomical position, the thumb position's out here. The basilic vein is going to be on the little finger side coming out this way. It's going to go up the lateral aspect. I'll go back to this one. It's going to come up the lateral aspect of the forearm, the medial aspect of the forearm, rather, from anatomical position. And it's going to come all the way up into that antecubital fossa and then continue until it enters into the dorsopectoral triangle and eventually dumping into the axillary vein up into the armpit there. On the lateral side, on the thumb side, you've got the cephalic vein. You can see it here coming in. Well, let's go back to this shot. The cephalic vein coming on the lateral side, the thumb side coming up. And again, it's going to go into the deltopectoral triangle as well and eventually dump into the axillary vein as well. But the basilic vein dumps in just a little more distal to the cephalic than the cephalic here. So they both come up into the axillary vein, but the cephalic is going to, the basilic is going to be just a little more distal than that. Now, one way I remember this, if this is helpful to you, Bethel University, BU, the basilic vein is on the ulnar side, if that helps you. The basilic vein, ulnar side, cephalic vein, radial side. So CR, I don't know how you want to mention, remember that, Coon Rapids maybe, but BU, basilic vein, ulnar side is going to come up this way. So you can see here, they both come down, they start draining actually off of this dorsal venous arch in the back of the hand here, this dorsal venous arch, and they just start coming up into the forearms here. So more commonly, like I said, you're not going to have this pattern quite as often. Here you can kind of see how there's this medial basilic vein, this medial cephalic vein that join in with the cephalic and the basilic continuing up. Really, most of you are going to have this pattern here where the basilic comes up and just continues up, and then there's this cephalic vein on the radial side coming up. It continues, but then it's joined with this. This vein here, the medial cubital vein, which is oftentimes where they'll draw blood coming into that vein there. Checking your blood pressure as well with the blood pressure cuff and the stethoscope, checking in at that venous portion there of the medial cubital vein. Okay, hopefully that wasn't as complicated as I made it sound there for a minute. Now let's just finish with some review of the musculature of the shoulder very quickly here. Hopefully this is review again, but just to see, you'll be seeing some of this stuff as you dissect down. Remember the trapezius, this trapezoid with it's like a big triangle with the head cut off here. You can see the trapezius coming from the spine of the scapula, the clavicle coming up. Really from the spine, the spine all the way from all the way through the cervical spine down into the lower thoracic spine, and then coming up to the lateral border of the scapula and the scapular spine and clavicle for its attachments. You can see the latissimus dorsi, this large muscle here, coming from again, the spine, the thoracic and lumbar and sacral spines, the crest of the pelvis, coming underneath the arm and attaching around to the intertubercular groove on the anterior aspect of the humerus it doesn't actually touch the scapula, so it's going to pull the arm back. It's going to be a shoulder extensor and internal rotator. Trapezius will do a few things. It will elevate the scapula, it will retract the scapula, and it will depress the scapula. So depending on if it's the lower trapezius, the middle trapezius, or the upper portions here, depending on which fibers are being activated, you'll have a few different options there. The rhomboid, you can see the trapezius is dissected off here. The rhomboids, rhomboid major and minor. Minor is the smaller one up on top, from the medial border of the scapula to the spine to retract and elevate the scapula slightly here. Levator scapulae, coming off of the first 4 vertebrae of the neck, coming down to the superior angle of the scapula as another scapular elevator. If the scapula is stabilized, this will actually laterally bend the neck, coming down this way too, depending on which is moving. Let's see, deltoid like a triangle. You can see just the back of it here. I don't have an anterior. Here's an anterior view. Here's the posterior view and an anterior view coming from the clavicle on the anterior side, coming towards the acromion, and then back on the spine of the clavicle, coming down this way. So it kind of goes, the spine of the scapula, rather. So from the clavicle, hooking around the spine of the scapula is the deltoid muscle. I know this is your left deltoid and this is your right deltoid. Don't get that confused. This picture is looking at the anterior aspect of the right shoulder. This is looking at here's the posterior aspect of the left shoulder. So just to get your reference points. But they all come down and attach to the common insertion here at the deltoid tuberosity, about halfway down the shaft of the humerus on the lateral side. Pectoralis major, coming down here off of the clavicle, the sternum, and the ribs, coming over, converging onto the humerus again, and near that intertubercular groove next to the latissimus dorsi. There. Serratus anterior, you can see sneaking through here. Here's another shot of serratus anterior, coming again from the first 9 ribs, going in between, anterior to the anterior aspect of the scapula, attaching to the medial border of the scapula to help hold the shoulder blade onto the rib cage as the arm moves. A good scapular stabilizer. Here you can see the rotator cuff, the supraspinatus up on top of the spine of the scapula, the infraspinatus here, teres minor coming back here. The infraspinatus and teres minor are external rotators. Supraspinatus is an abductor, abductor of the arm. And here's teres major. This is not a rotator cuff muscle, but again from the lateral or axillary border of the scapula coming onto the anterior portion of the humerus, next to that latissimus dorsi attachment is the teres major. Teres minor is one of the rotator cuff attachers. Musculature, and the anterior spot here, I don't know maybe there's one here. Here you can see the subscapularis, the anterior aspect of the scapula coming around towards that lesser tuberosity of the humerus. for an internal rotator. And then teres major, we mentioned that one already, coming on the anterior. Here's a good shot of teres minor being still there, infraspinatus being cut. And then here you can see teres major coming underneath the, let's go back to this picture. Here you can see latissimus. Here's teres major. They come up together on the anterior aspect. They're coming underneath the arm, being an internal rotator of the humerus. So we'll look more closely at these upper extremity muscles in the next dissection, but just wanted to review a little today. That's enough of me talking with you. So let's see you in lab, and I hope that was helpful. Hopefully you learned something, and I look forward to talking to you again. Have a great rest of your day.